Yes, sir.
Okay.
Yes, sir.
Right. So this was now this just to teach you some of the basics. It is little away from your normal answer for the question that has been asked. I thought better to learn a little basics of coagulation. So hemostasis uh, describes these things. We mean blood stasis being stopped. It's a process in which a series of reactions occur among coagulation proteins to finally end up in a conversion of soluble fibrinogen into insoluble fibrin. So this is the definition. So you can see that once you tickle that, all the things that they fall and then try to produce this change. What is the purpose of coagulation? To maintain balance between pro and anticoagulation factors. So this should always be in equivalent. So when there is no trauma or anything, body should keep the blood in a fluid state. It cannot afford to make a solid or a semi-solid form of the blood. So body in a normal vascular system tries to keep the blood in a liquid phase. For that you need anticoagulation factors. Whereas once you have an injury or a damage to the vessel, then the blood should clot at that level to prevent you from bleeding to death. So that is a procoagulation state. So there is always a balance between the pro and anticoagulation factors in our body. Now, what are the components which are involved in the formation of clot or the coagulation process? You have these important structures called the intima, the media, and adventitia of the vasculature, and also called the extracellular matrix, ECM. So, vascular endothelium forms an important component, and these are the things that are involved in that. So, this picture tells you what are the structures which will be involved in that. The endothelial cells are there, the nitric oxide which is affecting that, the extracellular matrix which will get exposed if there is a discontinuity in the endothelial cell layer, and there are elastic laminae, and there are nitric oxide producing macrophages, fibroblasts, etc. are all present in that particular thing. So this is the first component which is involved in the component. Second is the platelet, which is the initiator of coagulation. So platelets, they form this sort of aggregation. So third is the plasma clotting factors, which are all getting converted, or they are different proteins and enzyme systems which are interacting with each other and ultimately forming that. So the clotting factors, to remember that, we have a mnemonic called Precious Party Tonight. Come, let us sing, and also call seniors, please have fun. So if you remember that, you can remember all the 12 clotting factors. And in a healthy, intact endothelium, you have antithrombotic factors which keep the blood in a liquid phase. So what are the antithrombotic factors? If you see that, you have this three things. It's called the thrombomodulin, heparan sulfate, and this antithrombic 3 factor is there, which prevents the conversion of factor 10A in thrombin reaction. And this thrombomodulin is also is a converter of C protein, and prostaglandin, nitric oxide, C39. All these things are antithrombotic. And of course, you have among the coagulation factors, you have the protein C and S. And, this inhibitor of tissue plasmin activator. All these things are the antithrombotic agents which keep the blood in a liquid phase without forming a intravascular thrombus or clot. That when you develop an injury or a damage, then the prothrombotic or coagulation factors come into play. And these are the extrinsic and intrinsic pathways which initiate that. So they have been described as extrinsic pathway and intrinsic pathway, which both of them meet at a particular point to end in what is called the common pathway. So this is how the whole thing happen. So when there is an injury to the endothelium, it exposes the extracellular matrix area. So here you can see this is the vessel wall injury, where there is a disruption of the lining of the endothelium, which exposes the subendothelial matrix. And this subendothelial space has got collagen, von Willebrand factor, and platelet adhesion glycoprotein. All these things are present in the subendothelial area. And the tissue factors which initiate coagulation cascade is expressed in fibroblast and this extrinsic pathway outside the lumen of the blood vessel. So that is why it is called the extrinsic pathway, because these factors are present outside the blood vessel, whereas the intrinsic pathway is mainly all the coagulation factors which are present in a soluble form merged in the blood itself. So that is the reason why we have these two pathways. One is the intrinsic pathway containing all the coagulation factors, and the tissue factors and the fibroblasts which are present outside the vessel, which is rules to the extrinsic pathway. So the first and foremost thing we have to know is about the platelets, which is derived from the megakaryocytes. What is the peculiarity about platelet structure? The difference between other cells or a similarity between RBC and platelet? Why
No
platelet has
nucleus.
got no nucleus? That is why their lifespan is very, very short. What is the lifespan of a platelet?
7 days, sir.
5 to 7 days, exactly. Very good. So it's a non-nucleated structure which has a short span of 4 to 7 days. It's a membrane is highly reactive when it comes into contact with extracellular matrix and undergoes what is called adhesion. So the first step in the clot formation is platelet adhesion. So the adhesion, actually the definition is an attachment between platelet and the extracellular matrix, non-platelet. Whereas attachment between multiple platelets is called, when platelets adhere to one over the other, keep on adding like a brick over a wall. What is that called?
Aggregation.
Aggregation. Yes. Platelet attaching to another platelet is called aggregation. Platelet attaching to non-platelet structure like extracellular matrix called adhesion. So the first step is the adhesion. Once it gets adhered, the platelet is broken down, that is activated, and then this will attract more platelets and attach themselves to each other. That is called the aggregation. So there are three phases in the activation of platelet: adhesion, activation, and aggregation. So the stage one, you can see all these things, how they form. This is the formation of platelet. So from the stem cell, you get the colonies in count. Then it comes to stage 3, where it forms what is called pro-megakaryocyte, megakaryoblast, then pro-megakaryocyte, and from megakaryocyte you get the platelet. So this is the whole formation from the stem cell of platelet. And these are the first step, adhesion, where there is a damage to the endothelium. You can see the subendothelial matrix is exposed. So immediately platelet will come and start getting attached to the subendothelial matrix. That is the adhesion. And immediately it gets broken down, or the membrane gets broken, it gets activated. And so von Willebrand factor is a bridging molecule between extracellular matrix and platelet GP1 receptor. And this is the first effort to stop the bleeding. But the platelets here attaching to the endothelium is very loosely attached. It is not very strongly bound. And this is known as the primary plug or hemostasis. Okay. Then the activation of platelets, when they get attached to the ECM, they are activated and they release their content. There are two types of storage granules inside the platelets, namely alpha and delta granules. The alpha is a thinner granule and delta is a dense granule. And alpha, when they release fibrinogen, von Willebrand factors, factors 5, 7, and platelet-derived growth factor. From the delta granules, you will get ADP, ATP, calcium, hydroxytryptamine, histamine, epinephrine. So this is the picture where you have the two types of granules, the dense granule and alpha granule, and the things that are liberated from that by breakdown of this platelet. And the third step is the aggregation. Now you can see here the platelets are attached to one another like a brick wall, and this is called the aggregation. Attachment of platelet to platelet is called the aggregation. So these are all the phases that help in that: tissue factor release, phospholipid composition, thrombin activation, fibrin polymerization. So all these things happen once the platelets start getting transfusion. So when platelets get activated, they attract more platelets, which is called aggregation. In addition to surface receptors of the platelet, namely GP2B3A, are exposed to bind with the fibrinogen that is converted to fibrin by thrombin to form the cross links and make this loose plug into a solid plug. That is called the secondary hemostasis. So the initial phase of platelet attachment produces only a loose plug. And then finally, when fibrin is also interspaced, which causes the cross-link, that is a cementing thing between the platelet, it becomes a secondary hemostasis plug or the strong hemostasis. And these are the coagulation factors identified so far, and the clotting factors which are mostly in the blood, they are all synthesized mostly in the liver. So except the of them synthesized except factor 8, 3 and 1 Willebrand factor. All others are synthesized mainly in the liver, and factor 6 has been removed. You see all the list of coagulation factors, you will find 5 and then it will go to 7. You don't have, so 1, 2, 3, 4, 5, 7 there. So the 6 has been removed because it was found to be the same factor which are identified earlier. And they have numbered them by Roman numerals of the normal 1, 2, 3 Arabic numerals. So this is the two things that you have to know about this clotting factor. And these are all the various factors which are there, which you have to remember. And the pathway is classical pathway and cell-based pathway. There are two pathways described for coagulation. One is called the intrinsic pathway, which is activated by the extrinsic pathway, finally resulting in final common pathway. Now, this picture, most of you may be knowing that the extrinsic pathway after a trauma or injury, which is the factor 7A and tissue factor which gets activated. Ultimately, it is the factor 10A which is dormant will be, when you say A, it is activated. Before that, it would have been a dormant state, soluble state. Once they get activated, then they go on to react with each other. So the final common pathway is conversion of fibrinogen to fibrin by the prothrombin getting converted to thrombin, which activates the fibrinogen to form the fibrin. And factor 13A, which helps in the cross-linked fibrin clot. And of course, later the fibrin clot will be lysed depending upon the requirement of clot. Excess clot will be lysed to remove the wanted clot formation there. So this is the very simplified picture of the 10 steps. And these things were, what is the pitfall of this classical pathway is it was done in the test tubes or in the lab. So it's not done in the human body. So it failed to reveal the role of factor 7 in the integration of extrinsic and intrinsic pathway. And it also offers no explanation as how deficiency of factor 12 does not cause undue bleeding. And why in hemophilia there is no support by the thrombin formed to control bleeding. So these questions are not answered in the description of the classical pathway, and hence there was an alternate concept was formulated, which is called the cell-mediated pathway. So in the cell-mediated, it was actually this lady called Marine Hoffman. She only described that. And all reactions are said to take place on the surface of two different types of cells, mainly the platelets and cells with the tissue factor on their surface like fibroblasts and smooth muscle. So these are the two important structures which produce the pathway, and it occurs in three phases which overlap with each other. Unlike the earlier concept of a separate extrinsic, separate intrinsic, which finally meet in the final common pathway, they say these three phases overlap with each other, and the three phases that they claim are initiation, amplification, and propagation, where all these factors are interlinked with each other. So that is the first thing that happens. And the second is the amplification, third is the propagation, which results in the final formation of so this is one easy way to remember the steps of coagulation. Step 1 is draw the target 10. That is the factor 10 has to be the main factor which actually integrates both the intrinsic and extrinsic pathway. So first draw this 10. Second step is write the numbers from 12 to 8. Exclude the 10 because already you have put the 10. And this is the intrinsic pathway. That is 10, 7, 9, and 8 you can write. And step 3 is the write 7 for the extrinsic pathway, which is the factor 7 which is responsible for that. And step 4 is to draw the common pathway, which is the multiplication of 5 into 2. Factor 5 into 2 results in 1. So you write like that, it's easy to remember the steps. Now, what is the applied physiology for this? Von Willebrand factor deficiency causes bleeding due to failure of primary hemostasis. As we saw that once the endothelium is disrupted and the subendothelial matrix is exposed, this von Willebrand factor only causes the adhesion of the platelet to the TRA area. So that will, if there is a deficiency of von Willebrand factor, platelet cannot come and occupy that place, resulting in the failure of the loose platelet plug or the primary hemostasis. Then platelet can be deficient in number or its function, which can also lead to failure of clot formation, resulting in excessive blood loss. So this is purely a platelet deficiency. For example, if you specifically block the action of platelet by antiplatelet agents like your aspirin, clopidogrel, that also can lead to bleeding because platelet is not functioning normally. So first factor is von Willebrand deficiency, second is platelet insufficiency or inefficiency, and third is the plasma coagulation factor deficiency, resulting in failure of proceeding of the cascade of changes that have to take place leading to blood loss. So these are the three major things that we have to remember. And failure of anticoagulation factors lead to excess coagulation that can lead to thrombus alternatively. And deficiency of antithrombin 3, protein C, and protein S are the common causes to promote intravascular coagulation, which are called the antithrombotic agents. Antithrombin 3, protein C, and protein S. They only help in the normal intact endothelium. They only help in the blood remaining as a liquid or a fluid state. And the excessive presence of antiphospholipid antibodies and homocysteine also promote thrombosis. So nowadays we always do a estimation of homocysteine when we do a routine master health checkup for any individual. And if the homocysteine levels are more, they are supposed to be prothrombotic. That is the reason why they can develop acute coronary syndrome. So patients who have high homocysteine level, that has to be removed by giving them more of vitamin B12. So that forms a complex which reduces the homocysteine activity, which will reduce the thrombus formation. And rarely primary thrombocytopenia or cytopenia with platelet count is abnormally high can also cause spontaneous thrombosis. And of course, evaluation of coagulation, you can do history taking, lab-based tests, and point-of-care coagulation test. This is the last one which was included. This was about 15 years ago. So at that time itself, this has become That was the time when it was becoming more important. That's the point of the coagulation. So, what are the important history you have to take is to ask for any undue bleeding tendency or prothrombotic tendency. Questions that you ask: have you had excessive bleeding during trauma or surgery? Or even you can ask for excessive bleeding during menstruation. Any need for blood transfusion because of bleeding or re-exploration to control bleeding after a surgery? Any frequent spontaneous epistaxis? Oral bleeding during routine brushing or during any dental procedure? In female, menorrhagia or postpartum hemorrhage? Spontaneous hemorrhage into joints like hemophilia patients? Age of occurrence of this episodes of bleeding? History of intake of aspirin, NSAIDs, herbs, fish oil or garlic? Garlic, you remember, is a very potent anticoagulant. So patients who take a lot of garlic, it is almost like your antiplatelet effect. Patients may have more bleeding. And coexisting diseases like renal, hepatic, thyroid, bone marrow disorders can also cause bleeding disorders. And if the patient obese, for thrombotic tendency, these are all the questions that you have to ask. Whether they are undergoing orthopedic or major abdominal surgery. If the patient is on oral contraceptives, especially female, they have a thrombotic tendency. If the patient pregnant, it also produces a prothrombotic patient, and it can be, are they going to be immobile for long after surgery? That is another important reason for thrombus formation. Malignancy produces prothrombotic state. History of prior DVT, history of angina, and history of previous stroke. All these things indicate that they can have a thrombus. Now, indications for lab testing. History of history reveals signs and symptoms of bleeding disorder. Cases where major surgery is possible, chance of bleeding is anticipated, like cardiopulmonary bypass surgery or liver transplantation. In patients who are not able to provide a bleeding history, but clinical suspicion points to such condition. In these patients, we have to do the lab testing. And if any bleeding disorder or thrombotic tendency is detected preoperatively, underlying mechanism must be ascertained before proceeding with surgery, especially in elective cases. And lab-based measurements are platelet count. I'll go through that quickly because this is a routine thing that we do, will not relevant to the questions that have been asked for the exam say. So bleeding time, clotting time, they have all become obsolete. Now they don't do that because with the availability of this other tests which we normally do. Prothrombin time we are still doing in majority of the cases. This assesses the extrinsic and common pathway. That is what we have to remember. Prothrombin time PT helps to assess the extrinsic and common pathway and is expressed in four ways. PT with control value, PT as INR, PT ratio and PT index. So this is how it can be expressed. And INR, which we normally use today also, PT-INR, was introduced as a standardized to result the prothrombin time because each lab had a different reagent. So they produced a different range of normal values. So in order to make it uniform, this INR was introduced as an international normalized ratio. So PT test is done by the addition of tissue factor to patient's plasma. That is the extrinsic pathway activation, and the time to clot formation is calculated. Because various standards of tissue factor are used in different labs, the values obtained were also different. So in order to standardize that, calculated is the following way. INR is equal to what is the observed value, PT test value divided by PT control into the international standardized numerical. So ISI is a numerical value representing the responsiveness of any given commercial agent relative to the international standard. So this is how actually you have to calculate the INR. And normal value is between 0.8 to 1.2 seconds. So anything higher than that sometimes we use the INR also to assess the achievement of anticoagulation. For example, patients who have a prosthetic valve, when we want to prevent any clot formation in the valve, we give them anticoagulants either in the oral form of vitamin K antagonist or other antiplatelet agent or even heparin, and maintain the INR at a higher value so that they don't form any clot over that valve and other areas. So PTINR is used both for assessing the normal value of clot formation as well as for adequacy of anticoagulation. And activated partial thromboplastin time, which we still use even today to assess the intrinsic and common pathway. So PTINR assesses the extrinsic and common pathway. APTT assesses the intrinsic and common pathway, and their normal value is between 25 and 35 seconds. Abnormal values indicate deficiency of most of the coagulation factors, and except factor 7, which is of course for the extrinsic pathway. So all the other factors are supposed to be deficient in. And thrombin time, which is still used even today, it is a lab-based test and helps in the formation of thrombin and fibrinogen, and their normal value is 15 to 19. So what is the indication for thrombin time today? When will you order for a thrombin time? CT. Okay, so you can tell me. So thrombin time bypasses factors 12, measures the rate of fibrinogen conversion to fibrin. Procedure add thrombin with patient plasma and measure the time to clot. Variables are source quantity of thrombin. So we nowadays use anticoagulants which are called direct thrombin inhibitors. Newer oral anticoagulation agents which are called direct thrombin inhibitors. So whenever you use the drug, only this test will be able to tell you the efficacy of the drug or uh, the effect of the drug. Then of course respiration, if it is not done, just skip through that. And anti-factor 10A, which is done with the most of the factor 10A anticoagulants, and this is fibrinogen level. This test of fibrinolysis is by assessing the D dimer value, which is important for DAC, DVT, and pulmonary embolism. And these are all the things which are based on that. Now comes the point of care test, also known as near patient test. So to eliminate the certain drawbacks of lab-based tests, like to reduce the time delay in getting the result, avoiding testing of plasma at a standard exposed temperature, lack of information on platelets. Advantage of point of care testing are results are provided faster, less volume of whole blood is used, and less transportation hazards, helps in blood component and drug therapy. Replace exactly the test factor which is deficient. And these tests are classified into monitoring heparin anticoagulation, measuring the intrinsic ability of blood to form a clot, or viscoelastic measures of coagulation. So the point of care testing of coagulation and broadly classified into that. So you can measure both the anticoagulation effect as well as the coagulation. And thirdly, you can also assess the platelet function monitors are there, and clotting factor tests are also there. So all the four things are done with the point of care test. So the functional assay of monitoring heparin and anticoagulation is done by activated clotting time, which we use routinely during cardiac surgery. The advantages: the low cost, simple operation, linear response to human heparin dose. Disadvantages are less sensitive at low heparin concentration, false value with hypothermia, coagulation factor that we will see, and BP3 inhibitors will give a wrong value. And warfarin patients also you will not get the correct value. Platelet function abnormalities also will not give the correct answer. So this is the machine that we use. We insert the specimen into that and we will get the result displayed here. And high dose thrombin time, another functional assay of heparin anticoagulation. Now, viscoelastic measures, they are mainly by thromboelastography, which was introduced first, analyzes and displays all stages of clot formation and resolution of the clot also, and analyzes the interaction between platelet fibrinogen and coagulation, and uses only 0.35 ml of blood into 2 cups, gives a cigar-shaped graphical display. So this is how the whole thing is introduced. And here the cup rotates. The pin that is inserted into the blood sample stays stationary. Whereas in the rotametry, the pin rotates. So the cigar-shaped curve that you get reacts to all these things. Initial phase is coagulation and final phase is fibrinolysis. So the R time is the reaction time for the first significant clot formation, and K indicates the achievement of certain clot firmness. And this alpha angle indicates the kinetics of clot development. Then maximum amplitude of the clot formation, and then lysis occurring after 30 minutes of maximum amplitude, and finally the end of lysis due to this shape of the curve. And the tag value interpretation and corrections. So using this tag value, these 4 important values are there: R time value, and I'm sorry, alpha angle, maximum amplitude, and lysis. These are the 4 values which we have to look into. If R time, that is the initiation of clotting, is prolonged, then you have to give the plasma transfusion, which will contain all the factors as well as the cryoprecipitate, everything will be there. So you give the plasma for correction of R time prolongation. If the alpha angle, which shows the decrease in the thrombin level and fibrinogen in the clot formation, then we have to give cryoprecipitate or large volumes of plasma infusion. If the maximum amplitude is not achieved, if the clot is very thin, then it increases the indicates the platelets. So we have to give platelet transfusion, or you can give uh, DDPAP injections, dexamethasone, and which will activate the platelet efficiency. So this injection, in case the platelet number is not normal, but the platelet is not functioning, that condition is called thrombasthenia, which can happen in renal failure patients. So there, instead of giving platelet transfusion, you have to only activate the platelet which is available by giving this desmopressin injection. And if the lysis is very high and clot is not stable, then it's an indication for tranexamic acid or aminocaproic acid. So these are the 4 things that we can remember with regard to sleep. Rotation thromboelastography, which is nothing but a modification of tech, which uses tissue factor like hyaline, uses tissue factor, unlike the tech which uses kaolin to make the clot formation. And it can be more useful in patients who have had heparinization done. So if patient is received heparin, the stuffs contain an enzyme called heparinase, which will counteract the heparin and also assess the coagulation formation. And the graph that you get is also more or less the same thing, but instead of the R time, you have the clotting time, and you have the clot formation time, and again you have the alpha angle. Then you have the amplitude at 10 minutes and maximum clot formation firmness. Then you have lysis at 30 minutes and maximum lysis level. So a small change here is there is no R time. is CT, clotting time. And the alpha angle is present here also. And there is another thing called the, instead of K time, you have the CFT, clot formation time. So these are the small differences between the peg and the rotation, and this is how the machine looks like. Then there is another thing called chronoclast, which is a vertical vibrating probe inserted into a zero point 0.4 ml of blood, and the impedance to its vibration produces a electrical signal, which is plotted as a surgical graph. This is the machine that you get. This is how the signature plotted here. R time, R2, R3 are the 3 times. So the formation of clot, the peak formation and clot retraction, all these things are designed by that. This also assesses the effect of the various coagulation. The platelet function monitor is traditionally based on the lab-based test, but they're used to detect in the surface receptor of platelets. And it analyzes, there is a machine called platelet function analyzer 100, which measures the adhesion and aggregation capability of platelets. And useful in detecting aspirin-mediated platelet dysfunction and von Willebrand disease, and hemodilution and thrombocytopenia. This is called the Innovance PX platelet function analyzer. Then clotting factors testing. PT, APTT, INR routinely measured in the hospital, now on the bedside, and patients who are on warfarin therapy. And besides INR, be done in surgical patients on warfarin therapy also. So the take-home message is, these are the things: vascular endothelium, platelets, and coagulation factors form the backbone of coagulation. And the balance between pro and anticoagulation pathway is important to avoid bleeding or thrombosis. Cell-based pathway seems to be correct way to describe the coagulation, likely to replace the classical pathway. And diligent history is very important. And time is not far away. Contact tests are to replace traditional lab-based. So this is the message that was given 15 years ago. And that was the end of that presentation. Thank you.